Just wanted to briefly go over some overarching themes, just some basics of metabolism and how our body processes different types of food. Major hormones related to metabolic health being mainly insulin, as well as the liver, which are both key players in metabolic health. Metabolic syndrome, which is extremely common, what it is and how we can define it and what we can look for. And then progressing from metabolic syndrome, you can have several offshoots of different metabolic diseases that can affect different parts of your body. We'll touch upon how it's all connected and then what we can do to treat if we're already at this stage where we're having some metabolic diseases, and also ways we can try to prevent the development or progression of metabolic diseases. Just wanted to also touch upon some of the great classes you've already gotten before. I love the nutrition emphasis, and food really is at the most basic form. It is medicine, so it's very important to realize that and really get that point across. And then also prevention is the best medicine and prevention is the best treatment. So if we can do our bodies good by having healthy intake now, it will really benefit us later in life and allow us to live as independently as possible and for as long as possible. So just an overview about what metabolism is. It's a set of chemical processes by which our body converts food and drink into energy. Our body then will use that energy to do voluntary and involuntary things, including digestion, cellular repair, cognition. It affects our immunity and our ability to fight off infections. So it's very important to have good metabolic health. It's also really important because understanding where it can go wrong and be dysregulated, metabolic dysfunction can really affect every organ in our body and can manifest in many different ways and many different disease processes. And then this idea of metabolic health would be how well our bodies can generate, process, and use energy. So there's a couple common macronutrients, and you may have heard of these before: carbohydrates or carbs, fats or lipids, and then proteins. These are the main three macronutrients. There's also several micronutrients that we won't touch upon too much today, but these are the major fuel sources for our body. Carbs or carbohydrates are primarily broken down into sugar, and we'll touch a little bit about this, but there's a wide variety of carbs, and they can include a spectrum of things from bread to fruits and vegetables, fiber, so some very simple carbs and some more complex carbs. And our body will then break those down and store them as energy in the form of glycogen and also fat. Moving on to fats, these can be found in things like nuts, seeds, oils, and butter. They are important for maintaining integrity of our cells in our body, as they're involved in the components of cell walls. And it's also important for our bodies to store fat appropriately, which then can be used later on as fuel. And we store fat both in visceral and subcutaneous regions, which we will talk about in a little bit as well. And then moving on to protein, which are broken into amino acids used to build and repair tissues, as well as used to make enzymes and hormones. And these can also be converted to glucose if needed. There's some images of some sources of protein. Animal and plant-based protein alike have positive effects. Don't really want to focus on one or the other. A combination of both high quality is really what we would recommend. There's some pictures of chicken, some fish, chickpeas, tofu, yogurt, and it's really important to ensure adequate protein intake. The American Dietitian Association recommends a minimum of 0.8 grams per kilogram. So I like to think about my body weight. And then if you divide your body weight by 2, that should be around the minimum amount of protein in grams that you should be eating per day. So for a 150-pound person, that would be a goal of 75 grams of protein a day, which can seem like a lot, but incorporating protein from a variety of sources, like a handful of nuts or some chickpeas throughout the day, can both help keep you satiated or not make you feel as hungry, and then also maintain muscle mass, which we know is very important for longevity and independent mobility as we get older. This is another important concept that I wanted to touch upon is glycemic index. And you may hear this when people talk about different types of carbohydrates, but basically it's a scale that tells us how fast a specific food will raise blood sugar levels after they are consumed. Foods with a higher glycemic index tend to increase blood sugar faster than foods with a lower glycemic index. So let's say in the morning you have a donut for breakfast, it tastes great, you feel good for about an hour, and then you start to not feel as energized as you initially did after you first ate that delicious donut. And this is an image of what's happening where You initially have that rise in blood sugar, you have a lot of energy, but very rapidly your body will process that donut because it's more of simple carbs and it will not provide your body with a sustained amount of energy and fullness. And if you look at some of the other examples of high and low glycemic index foods, some of the high glycemic index would be like chips, ice cream, cakes, all the things that we love, but maybe ultra processed in nature, which makes it very easy to digest for our body. And if our body digests things too quickly, that's when we really get that high spike in glucose. Whereas if we look at some of the more complex forms of carbohydrates, things like legumes, whole grains, potatoes with skin, and in general, things with skin have a little bit more fiber to them, and that can cause our body to have more of a sustained release, more of a monitored blood sugar level versus a rapid peak and trough, which can lead to dysfunction later on.
Why do we crave bread? Why do we crave carbohydrates? And does this fall somewhere in this cycle of rising and falling sugar?
Definitely. It's interesting. There's a few different thought processes between why we crave certain foods. One is within our brain, there's a dopamine reward system pathway, and some very simple high sugar foods really spike that dopamine pathway. When you look at brain imaging of someone that eats a donut, their dopamine, their reward system really lights up because they really love that donut and it makes them feel good. We really try to recreate that dopamine surge a lot. That's one thought process. Another is that with these ultra processed foods, they're considered to be hyper palatable, meaning that there's a lot of added sugar or flavors in there that our body craves and hits a lot of the specifically sugar receptors. Then separately, which is more of a new developing field, is like the microbiome. There's been some research maybe suggesting that the types of bacteria that we have in our bodies actually can dictate the type of food that we crave. The more of a certain type of food we eat, the more our body adjusts in terms of the bacteria population to become used to that food. And then we start to crave that food because that's the type of food that the bacteria eats. So this mind-gut connection really can have a pronounced effect on what we go to grab out of the fridge, which is very interesting. Just highlighting some of the complex carbs, things with a lot of fiber in them, either soluble or insoluble fiber. It's not digested by our body as easily as something like a simple carbohydrate. So it makes our bodies work longer to try to digest food. And then you have that more gradual release of sugar. If you think about what you want to eat first in the day, depending on when your first meal is, or very early on when you wake up, you want to make sure that you have a good source of protein when you wake up as early as possible, because if we eat carbohydrates before we eat protein, our body does not become full as quickly. So we want to make sure that our first meal of the day, whenever that is, that it involves a significant amount of protein. They recommend up to 20 to 40 grams, which can be quite a lot, but that would also be about the size of a bowl of Greek yogurt along with a handful of nuts or something along those lines. So something that is doable, but it's important to think about getting that protein in as early as possible. One of the major hormones in metabolic disease, insulin, this is considered an anabolic hormone, and you may have heard anabolic in terms of like steroids, where bodybuilders, they get beefed up and they take these steroids to try to gain as much muscle as possible. Insulin is a different type of hormone, but it also promotes growth and storage. Going back to our hunter-gatherer origins, we were not used to eating 3 meals a day. We were used to scavenging, and if we were able to get a meal or find berries or something like that, we would eat, and then our body would store that energy for later use. Now in today's society, where there's food that's rapidly accessible at every corner, our body doesn't really need to utilize a lot of that stored energy, and that's where it can become a problem. So the role of insulin, it causes basically glucose or sugar uptake in cells and storage, and that can manifest in fat cell production. It can also manifest in protein synthesis and then glycogen glycogen, which is a longer chain of glucose that is stored both in the liver and in muscle. A normal function of this would be you eat, the blood sugar rises as we discussed before. The pancreas, which is an organ in your mid-stomach, releases this insulin, and then it allows your body to process this glucose, and the blood sugar level will drop again. What can happen is we become resistant to insulin. Basically, when anything becomes resistant to something else, it's not as sensitive when you get that signal. So our body is constantly exposed to insulin, and we're not able to take in that sugar as quickly as we previously were. So we require more insulin to try to compensate for that. But then because our body is not as sensitive to insulin, we can actually think that our blood sugar is low because our cells are not able to adequately take up that sugar, which can further worsen that high blood sugar or that hyperglycemia term, because our body then tries to mobilize other units of energy, such as fat or glycogen, to try to give our bodies the energy that it thinks that we need. And then simultaneously, while this is happening, the other functions of insulin are also happening. Like we talked about at the beginning, it promotes growth and storage. So other things like fat will develop, and it can develop in the abdomen or in extremities as well. So it's a double-edged sword here when you have insulin resistance. Just a quick side note, in patients with type 1 diabetes, and we'll touch upon type 2 diabetes, but patients with type 1 diabetes, they do not produce insulin through an autoimmune mechanism. So they require exogenous or basically patient-administered insulin in order to maintain their blood sugars. But they can also become insulin resistant. Over time, their body is exposed to high amounts of insulin, but through a little bit different mechanism. But I just wanted to make that point there. Moving on to the liver, which is my personal favorite organ in the body. It has several roles. It is important to both store and release glucose or sugar, and it stores in the form of glycogen, which, as I touched upon before, is linked glucose particles. If you can imagine that honeycomb-looking thing in the top left of that image there would be a square of glucose particles that are formed together into an energy unit. Then when our body needs to use energy, or if we're in a state of stress, our body can mobilize that glycogen and break them down into the glucose molecules so that other parts of our body can use that glucose or that sugar as energy, so that like our muscles can work, our brain can think, and things along those lines. It also is important for fat processing. It makes and packages and exports fats. It also makes and clears cholesterol, and it's a very important detoxifier for our body. It filters toxins from the blood. So it does a lot of things, and this is when it's working properly. However, when it does not work properly, our body can manifest with liver dysfunction in a few different ways. If we take in a lot of excess calories, our body needs to store these somewhere. Some goes into some subcutaneous fat in our body, but others can deposit in the liver because the liver is just trying to store energy for later. And over time, this can cause dysfunction, as we'll talk about in a little bit. It produces a lot of the basic building blocks for protein synthesis. It's involved with other hormones, and our ability to bleed and stop a bleed is very much dependent on the liver. So patients with liver disease commonly have issues both bleeding and clotting. So it really creates this double-edged sword that's hard to manage. Moving on to how we develop this metabolic dysfunction. I know we had touched upon it a little bit, but really want to drive this point home here. And the recurring theme will be insulin resistance. So we overeat, our body tries to store this as fat and glycogen, and then our body, due to these high levels of sugar in the blood, we get this insulin resistance and can lead to metabolic diseases. And these are just a few pathways where each of these can affect different organs in our body. So for instance, the cardiovascular pathway, which we have not really talked about too much yet, but high levels of cholesterol can cause inflammation and also can lead to high blood pressure, which can damage some blood vessels and cause plaque to build up, which can then lead to coronary artery disease, and then that can cause strokes, heart attacks, very bad things that can happen to our very important organs in our body. And moving on to metabolic syndrome. So this is a cluster of interconnected conditions that, when they occur together, increase your risk for heart disease, stroke, and type 2 diabetes. Basically, the diagnosis of this is you need to have 3 of 5 to be diagnosed with metabolic syndrome. A caveat here is that if you're being treated for any of these conditions, then that would automatically count as one of the criteria criteria, even if you were not having those lab abnormalities on the blood work. But going through them would be increased waist size. We measure around your belly button with a tape measure. In men, that's greater than 40 inches, and in women, it's greater than or equal to 35 inches. High triglycerides, greater than 150, which is a marker of a specific type of cholesterol. And then also having a low HDL, which is considered a good cholesterol, is also a part of this diagnosis. Having high blood pressure or being treated for high blood pressure with any medication for blood pressure would count as a criteria. Being treated for diabetes or having a high fasting glucose greater than 100 is a criteria. And that means basically your blood sugar remains high even when you're not eating. That's that fasting aspect, because our body's not able to bring in that sugar due to our inability to respond appropriately to insulin. So you get 3 of these 5, and that would give you the diagnosis of that. However, importantly to emphasize is that each of these criteria alone would increase your cardiovascular and metabolic risk. So together, they really exponentially can increase your risk for something very bad happening, but individually, each of them can also contribute to metabolic dysfunction. How common is this? It's extremely common, which is scary to think about. And a lot of these things we'll talk about, it's very common. More than 1 in 3 adults in the United States are affected or have metabolic syndrome. As you can see here, based upon ages, as we age, we are much more likely to develop metabolic syndrome. And this is from a variety of reasons. The main would be dietary choices and then also lack of mobility. If we look at a lot of the jobs that we have today, very few of them require us to stand or move or use our body in ways other than typing at a desk. I'm also victim of this, just keeping that in mind and trying to incorporate things just to keep our bodies from being sedentary. But as we get older, we're much more at risk to develop metabolic syndrome. Very important to note that the rates of metabolic syndrome vary based upon race and ethnicity. So Hispanic, and especially with the Mexican American population, they're at much higher risk for developing metabolic syndrome. Postmenopausal patients also have a much higher rate of metabolic syndrome. Also much higher in patients with HIV and on HIV treatment, as these can cause some metabolic dysfunction in and of itself, which can be frustrating because we're doing the right things, we're taking medications, and yet we can have some downstream side effects from that medication. So very important that we stay on top of it and try to prevent the development of some of these metabolic dysfunction outcomes. And moving on to obesity, which is really a central driver here. It's very interconnected among the conditions of metabolic syndrome and others. We classify it based upon BMI. I really want to put a caveat with the BMI because it was invented in 1830, so that's a very long time ago, and then it became popularized in the 1970s. So there are some concerns that it is outdated, does not really adequately represent the current day and age population, but it is the tool that we use to stratify patients into categories of obesity because it is one that we have highly accessible and it's universally used still. So you can see here a quote unquote normal BMI is between 18 and 25. Overweight between 25 and 30, and then obesity is considered in patients with greater BMI of 30. And a very important point is that not all fat is created equal. There's several different distributions of fat, but the main 2 are subcutaneous or visceral. And I like to think about the apple or the pear. So if we're an apple shape, a lot of our fat and adipose tissue is in our midsection and our bellies. And this can cause problems because this fat can encroach and become incorporated into our organs, such as our liver, such as our heart, such as our spleen and pancreas, causing them to not function as well. On the counter side of that, subcutaneous fat, where we store more in our hips or lower on in our midsection, is less metabolically disruptive due to its further proximity from our vital organs, and it does not really affect our organs as much as that visceral fat. So the visceral fat is what we really try to limit. Obesity drives dysfunction through a few different mechanisms. It causes some chronic low-grade inflammation. It increases insulin resistance, as we already talked about, and can cause elevated blood pressure, and it can also worsen our lipid profiles or our cholesterol, leading to cardiovascular disease, as we touched upon a little bit earlier. Moving on to type 2 diabetes. Most people have heard of type 2 diabetes or know someone that's affected by type 2 diabetes. More than 38 million people in the United States have type 2 diabetes, which is a very significant number. Already we touched upon how it develops with that insulin resistance becoming pre-diabetic, which is when our A1C, which is a marker. It's a blood test that kind of tells us the average blood sugar over a 3-month period. So it's used more of a long-term picture of someone's blood sugar control rather than a single snapshot in one moment. And if that greater than 6.5% or 6.4%, then you have the diagnosis of diabetes. In the early stages of this disease, there's not always a lot of noticeable symptoms. You can have some increased thirst, frequent urination, potentially some visual changes and some sensory changes. However, these do not always present until the patients have had a long-standing history of diabetes or their blood sugar is very poorly controlled. And basically, we develop these symptoms because the high sugar can become deposited in cells and cause them to behave abnormally. If you've ever heard of neuropathy or issues with sensation of like your fingers or your toes in patients with diabetes, this is because that sugar can become attached to some of the nerve cells and cause them not to function properly. So we're not really feeling things as we normally would, which can lead to issues with wounds, because if we can't really feel that we stepped on a nail, to a patient with normal blood sugar, they would be jumping out of their shoes. But someone with diabetes, they may have a difficult time feeling that, and they can have a very serious systemic infection from that. Just one example, but a similar idea can happen with the eyes, where very small cells can become damaged by that high blood sugar, causing you to have poor vision or vision changes. Cataracts is a very common etiology of some visual changes in patients with diabetes. Diabetes is the most common cause of chronic kidney disease in the US, and just because there's a lot of places where these sugar molecules can deposit and cause dysfunction. So very important that patients with diabetes really have their blood sugar as well controlled as they can. Every 6 months to a year, every patient that comes into our clinic that has diabetes, we do a foot exam. So we take their socks off. We do what's called a monofilament test, which basically is taking a non-sharp but very fine point filament and tapping on different parts of their foot to assess if they have neuropathy or lack of feeling. Also, we send them to the eye doctors to see if there's any damage from the diabetes there. And then the urine test can show if we're spilling protein, and that can be a sequelae or like a downstream effect of diabetes affecting our kidneys, because we're really not supposed to spill protein in the urine. And when we do, that's a telltale sign that our kidneys have been affected by diabetes.
You're talking about how important the liver is. Are the kidneys as important, or what is it that they do in relation to those processes?
Both of them work to filter blood, and I can see where they can have some overlapping functions. So as we talked about some of the major functions of the liver, where it produces some bleeding and clotting factors for our body, it is involved with storage of sugar and glycogen and produce proteins and things along those lines. The kidneys do a really good job of filtering the blood and also maintaining a good fluid balance and a salt balance within our body. If you ever see someone that has, or if you have a lot of fluid on your body, sometimes that is due to the kidneys retaining excess fluid because it thinks that our intravascular volume, or the volume of blood within our vessels, can be perceived as lower than what it really is. And then our kidneys can sometimes cause us to reaccumulate fluid. It can cause us to have too much fluid come off and have us urinating very frequently. So it does more of balancing the electrolytes, things like sodium, potassium. The acid-base status of our blood is more dictated by the kidneys, whereas the liver is more of a detoxifier in terms of their filtration abilities. We will touch a little bit more upon the liver here because it is my favorite. Here we talk about metabolic liver disease, and it's really a spectrum of disease. And if you've ever heard of fatty liver disease, that's what we're going to talk here. They have changed these terms, and their terms are used to make ourselves sound smart, but really all it means, it's a spectrum of the amount of fat deposition and inflammation within the liver. So on the right here, just for completion's sake, we recently changed the nomenclature, so it's MASLD and MASH, and basically this means that there is some fat within the liver for MASLD, or metabolic associated steatotic liver disease, which is a mouthful, but the key word here is metabolic dysfunction, and steatotic means fat or fat deposition. So on that left side here, we have some initial fat develop and deposit within the liver, and then it moves to the right where we see this develop of some inflammation, some early scar tissue formation, which is seen in MASH or metabolic associated steatohepatitis. That hepatitis aspect really indicates that there's some inflammation going on within the liver. And then moving further from there is cirrhosis. And cirrhosis is when there's a significant amount of scar tissue that replaces our normal architecture of the liver. And this can really cause significant abnormalities in the body. Liver cirrhosis can lead to a lot of downstream effects, like you can retain a lot of fluid within your abdomen, which can be called ascites. We talked about how there can be issues with bleeding. So you can get a lot of gastrointestinal bleeding or vomiting. You can get confusion, a yellowing of the skin or jaundice. You can have some issues with immunity and then wound healing, etc. So there's a lot of different functions that become compromised in patients with cirrhosis. And it's very hard to treat cirrhosis. Many patients require liver transplant for definitive treatment. So when we look at this spectrum of fatty liver disease, we really want to do our best to try to prevent the progression and that scar tissue formation. About 30% of the population has fatty liver. So it's very common. In the early stages, it's very difficult in what we call like an indolent presentation because most people do not have any symptoms that they have any fat in the liver. Some patients won't present until they have cirrhosis, so like fully scarred liver. So it's important to keep an eye on your metabolic health. If you have some other components of metabolic syndrome, your physician or whoever you're following with, your healthcare provider, should also look into screening you for metabolic liver disease, which we can sometimes get an idea of with some blood tests, but also some imaging. And we'll talk about that in a little bit as well, but very common. And then among patients with obesity, almost 70% of them have some component of fatty liver, so very prevalent. It is the most common cause of liver transplant in the United States, which has recently taken over hepatitis C and alcohol use. Touching on alcohol use, the fat deposition and scar tissue formation can really be exponentially worsened and progress much faster by simultaneous alcohol use or hepatitis infection. So we see patients that have some metabolic dysfunction, they have obesity, they have diabetes, and they also use alcohol or have alcohol use disorder. And those patients are at very much higher risk for developing MASH or significant scar tissue, potentially cirrhosis, than someone that does not use alcohol. Moving on to some cardiovascular complications, heart disease is the number one cause of death in patients with metabolic syndrome. So we really need to make sure that we're taking care of our heart by taking care of our other organ systems as well, leading to things like high blood pressure, coronary artery disease, as we discussed from that plaque deposition, other atherosclerosis, peripheral vascular disease. You can get pain with walking, or when you walk for a little bit of time, you feel like you have cramping in your legs. That can be a sign of poor blood flow, or you can see it within the brain itself. So there's a bunch of blood vessels everywhere, especially in the brain. If you have some atherosclerosis or plaque deposition within the brain, you can develop a stroke just due to lack of blood flow there. So very important that we keep our cholesterol under control and then also reduce risks with other metabolic interventions. One of the good news here, I know we've been talking a lot about negative aspects, but the risk of cardiovascular disease can really be reduced by lifestyle changes and improvements to metabolic health. And that really does go along with some of the other diseases that we talked about, like diabetes, like fatty liver disease, up to a certain extent. A lot of these can be significantly improved with lifestyle changes and potentially medications, as we will touch upon. Just for completeness sake, there's several other comorbidities that can be related to metabolic dysfunction. Sleep apnea, which is very underdiagnosed in this country. If your spouse ever tells you, oh, you wake up in the middle of the night gasping for air, or you're constantly snoring or sleep sitting up or in a recliner, these are some symptoms that may present in patients with sleep apnea. There's a very strong link with diabetes and obesity because we get a lot of redundant tissue around our neck. And when we sleep, our body isn't standing upright and able to hold that tissue out of the way. So we get a partial collapse within the back of our throats, and that can cause that apnea or that cessation or stopping of breathing intermittently throughout the night. And we know that a lot of patients with this will wake up with early morning headaches, they have high blood pressure, they feel tired all the time, and it can be difficult to diagnose this. So you really need to see a sleep doctor to do what's called a sleep study. They basically monitor the amount of times your body stops breathing over the course of one night. Touching upon chronic kidney disease, like we already touched upon before, diabetes is the number one cause. PCOS, or polycystic ovarian syndrome, a hormonal disorder in women linked to insulin resistance, also is very highly correlated with diabetes. And then certain cancers are even related to metabolic syndrome, including breast cancer, colon cancer, liver cancer. And we know this inflammation, that the fat deposition can cause cancer growth and can worsen cancer. We can move on to management and some lifestyle factors and modifications that we can do. Lifestyle modification is still the cornerstone. It is very effective for prevention and management of all metabolic conditions. So nutrition, we really want to focus on whole, unprocessed foods, really prioritizing protein and vegetables and fiber, limiting the amount of added sugar that we consume and having moderate portion sizes. We don't really want to overeat. That causes our body to really store that extra energy. We like to recommend a whole food plant-based diet, which means foods without food labels. So more produce stuff. And I know this can be easier said than done because it can be very expensive. Some things that we do here is like a community garden, or we have CSAs where we collaborate with local farms and they're able to distribute weekly or bi-weekly boxes of their produce, which is actually cheaper than what you'd buy from a grocery store, and it's farm to table. So we're supporting them. They support members of our community. So that's a really good way. I know within the city it can be difficult just with the land space, but maybe in the surrounding area there's some access to some farms. Physical activity, recommending 150 minutes of moderate activity a week. Seems like a lot. 150, that's 2.5 hours. However, if you break it down, 20 minutes per day, which can be even further broken down. We really want to also prioritize strength training. That can be done in the form of resistance bands. I have cans of soup. So you don't really need to go to the gym to really start your exercise routine. You can start with walking with 2 cans of soup, 1 in each hand, and that kind of added resistance will assist with burning calories and also strengthening muscle, especially if we're not used to exercising. We want to gradually work up to a higher intensity workout. We want to make sure that we reduce prolonged sitting. Any movement counts. So taking the stairs, small things that we can do throughout the day really help us. In the days where we did not have all electronic TVs everywhere, when we had to go up and change the channel physically on the TV, they've done studies here where if you get up to change the channel, instead of using the TV remote, you would lose an additional 2 to 5 pounds per year, which is crazy to think about. So what you can do is you can put the remote up near where the TV is, so you can mimic yourself going to change the channel. It also may lead you to watching the same show for several hours because you do not want to change the channel, but you can do some things which make you get up to disrupt that habit of sitting for a prolonged period of time.
That's a great example of how something that's a relatively small change can make such a big difference.
Definitely. And then really emphasizing sleep as well. Poor sleep can lead to weight gain, high blood pressure, headaches, daytime sleepiness, increased risk for infections. Making sure that we get 7 to 9 hours of high quality sleep, trying to limit the amount of stimulus, not using our phone within 30 minutes to an hour of bedtime, trying not to eat 2 hours before bedtime, 2 to 3 hours, which is very difficult. And then practicing mindfulness and wellness, which comes in the form of journaling, talking with friends, playing board games, sitting in the park, enjoying nature. None of this really matters if we don't have a strong mental health, because we really want to enjoy life, and having a positive outcome on life is the best way to drive our ability to make these changes in the rest of our lives. This is a quote that I really like by Michael Pollan: "Eat food, not too much, mostly plants." Eat food meaning real food, food without labels, as we talked about, not too much, making sure that we don't overeat, and then mostly plants. And regardless of what diet you choose, you want to make sure that you're using one that is a sustainable diet where you can really adhere to it, and you no longer consider it a diet, and you really consider it just the way that you eat and the types of food that you eat. As a physician, I would be remiss if I did not talk about some of the medical interventions that we can also use to assist with these improvements in your metabolic health. Although, as I said, lifestyle and activity is really the foundational support that we can build upon with medications. So please speak with your physicians or healthcare providers. They really would love to help you with this journey. Sometimes we can consider medications when lifestyle changes alone are insufficient, or you have some of these other metabolic syndrome risks that need to be managed with medication, like blood pressure medications, like diabetes. We really need to start thinking about obesity as a chronic disease, because it truly is. And it's one that you would need to manage for however long that you have it, but it's not a choice. And we really need to emphasize that with our patients, that hopefully going through some of this pathophysiology, you can understand that at the molecular level, there are changes that happen within the body, and it's not simply you choose to overeat. So really taking the stigma out of the patient and promoting their independence and their ability to take action in conjunction with the healthcare provider is really what we try to do at all of the clinics across the country, but especially here in Cincinnati as well. So comprehensive approach, you want to make sure that your blood pressure is well controlled, that your cholesterol is well controlled with statins or other lipid lowering therapies. Metformin is a very common medication to use in patients with diabetes. And then the anti-obesity medications, which are the hot topic and the talk of the town, or so to say, and in the medication realm, because they do pretty much everything. These GLP-1s, there is some stigma to them, unfortunately, within certain communities. People think that if someone were to use some of these medications, they're taking the easy way out, and I really don't want to promote that at all, because these medications are incredibly powerful. They cause significant weight loss, 15 to 25%. And if you yourself have experienced difficulty losing weight, or you have someone else that has had difficulty losing weight, you really know that it's not for a lack of trying, because you can diet and exercise all you want, but some people really have a very difficult time losing weight or getting their metabolism under control. And that's when these medications can be very helpful. They've shown improvement in diabetes control, heart health, kidney health, brain health after a stroke, and they're only getting better with the new ones that are coming to market. So very exciting time for metabolism, because before this, we really did not have a great medication for obesity. Every medication has side effects. I don't want to say that this medication is for everyone, but it is a medication that can help very many people. Just to close out, what you can do to prevent this is be aware, know your numbers, try to check your blood pressure, check your sugar or your cholesterol with your primary care physician. The best defense is the best offense. So trying to stay on top of it, increasing your movement, finding activities that you enjoy, start small and be consistent, mindful eating, trying to emphasize that whole foods, limiting the processed foods and sugar, prioritizing sleep, that 7 to 9 hour range with good sleep hygiene, and then really trying to avoid bad habits. I didn't really talk about this, but it is extremely important. That concurrent use of alcohol and tobacco can really worsen a lot of metabolic health. Managing those in addition to managing other metabolic diseases is really the best way in order to improve your outcomes if you do struggle with alcohol use or tobacco use. Some key takeaways: metabolic health is really interconnected. The early interventions matter, and lifestyle is foundational, and we can add some medical treatments on top of that to strengthen our ability to fight metabolic disease. Here's some resources that you can use. I meant to emphasize this point too, but we know that a 5% weight loss has significant clinical benefits. So you do not need to lose 20%, 30% of your body fat. Your goal should be a 5% weight loss, because we know that improves diabetes, cholesterol, blood pressure, but really attainable, achievable goals is enough to make systemic changes and improve our health overall.
You were talking about the microbiome as related to cravings for certain types of food. What do we do about that? If cravings are being defined by our microbiome, by that bacteria, how do you reset that? How do you work with that? Is it just about making dietary changes and then the microbiome changes? Or are there other things that you do in that process?
I want to reemphasize that this is like one of the theories that we have about our cravings. So it's not definitively like the only reason that we have cravings, but our body adapts and changes to the food that we intake. The best way to alter our microbiome in a positive way is to eat healthy foods. And over time, you will start to see you're not craving that salty snack, those chips anymore. You're not really craving those donuts, because your body is used to now running off a higher quality of energy, and it's used to getting missing fiber, which is grossly underutilized. So by making the changes, it's almost fake it till you make it, because you can eat it and then your body will start to actually crave it. But this is, like I said, one of the theories, but really trying to slowly incorporate a diverse group of foods into your diet, you'll see that you will start to crave those more and crave the ultra processed foods less.
You start eating more fruits and vegetables and you really start wanting them. Like you start reaching for fruit or vegetables because it is actually what you want in that moment. So experience seems to back that one up for sure. And it's a good feeling too. It's, oh, hey, the thing that I want is actually an apple. It does
Definitely.
actually change. And it's not just because you're trying to eat better, it's that you want that. And I think that's a really interesting function of what maybe our microbiome doing that.
Yes, definitely.